Hello, my name is Anna Brogan and I'm a registered nurse. Today I'm going to be discussing with you all the ethical debate topic of should do not resuscitate discussions be held in the ER. I chose this topic because I'm an emergency room nurse and I have realized that so many of my patients and their family members are forced to make decisions about death during active death, which is the absolute wrong time to have to be faced with these decisions. I personally have had patients who we're completely doing CPR on and trying to revive their heart after cardiac arrest. Their families walk in and say, "Stop, stop, stop. I don't think this is what my mom or dad would want." At that time, we stop CPR, and it's a brutal moment for all of us as a medical team because we realize that we've caused injury to this body to perform CPR, and this wasn't ever the patient's wish, but we had no way of knowing that. So this ER discussion pertaining to DNR orders is an interest to all nurses because it is so much easier to approach the DNR topic to patients in the ER who are coming and going because it's simple. In every medical and surgical history that the nurse is supposed to get in the ER, there's a little box at the bottom that says, does this patient have a DNR order on file? We're supposed to ask every patient that, and that opens up the door to say, this is what a do not resuscitate order means. It means in the event of your cardiac arrest, no CPR will be done, or CPR will be performed on you if you wish to not be a DNR. It does not mean that the patient is going to sign a DNR order or that we are at all advocating for that. It just simply means that we have the opportunity to ask our patients this and to do some teaching to our patient, which is our nursing responsibility. Some back history on the do not resuscitate order. Cardiopulmonary resuscitation, which involves chest compressions and breathing for a patient, developed in 1961 when anesthesiologists realized that patients who went into cardiac arrest after anesthetized procedures could receive CPR and be revived. This was fine and a great discovery for them at the time, but in 1974, the American Heart Association started to dig into these CPR cases. They discovered that only 8 to 39% of people who receive CPR during cardiac arrest return to normality, and the rest of these people suffer bodily injuries or neurological deficits due to the CPR performed and the time that their body is experiencing cardiac arrest. Now, the American Heart Association realized that this was a problem and that some patients simply did not want CPR to be performed because they had comorbidities or existing conditions that they had suffered through for long enough and they were ready to die whenever it was their time to die, but they did not have anything in writing. So CPR was performed on these patients, and oftentimes the patient was unhappy that they had lived, as dark as that may sound. Now, in 1991, which is some 30 years after CPR was accepted as the standard of care, the Patient Self-Determination Act was set forth. This Patient Self-Determination Act allowed for patients to sign do not resuscitate orders. So the patient, upon every hospitalization stay, would be presented with the topic of cardiopulmonary resuscitation, and if they wish to have this performed on them in the event of cardiac arrest. Now, this Self-Determination Act is something that should be so significant for nurses because as nurses, we allocate and protect patient autonomy, and this helped have our patients' autonomy and their wishes for death in writing, which is a huge deal in the nursing world because during death, we are still a patient's nurse, we still have to respect them, and we still want to do what they wish, even if we don't agree with it, whether it be for the patient to be a DNR or not. Do not resuscitate orders are not age-specific, gender-specific, or condition-specific. Lots of people who are young do not resuscitate or have do not resuscitate orders because they simply do not agree with CPR. And oftentimes, in the same token, older people who realize CPR would cause their body an extreme amount of damage still wish to have CPR performed on them because they want to have the fighting chance at life. Either of these decisions are fine, whether you're young and want to be a DNR or don't, or you're old and want to be a DNR and don't. That does not matter at all, and it should be every patient's choice. Now, the pros and cons of this issue are lengthy. The cons I would like to address first because the cons of an ER discussion pertaining to do not resuscitate orders seem to be the biggest deal. Cons pertaining to ER discussions about DNR orders include patients feeling like we're stepping on their toes. A lot of patients voice that when we discuss DNR orders with them, that we're stepping on their toes, and that it seems like we as the nurses are saying, if you die, are you a DNR? Because it's a whole lot easier for me not to do CPR on you. And that's not the case at all. As nurses, we want to do everything for you to honor your wishes. And it is our job as a nurse, if we sense that a patient feels like we're stepping on their toes by simply asking if they have DNR orders, it's our job to say, listen, this is part of our nursing responsibility. We want to do whatever your wishes are, and whether you're in the ER for a splinter or cardiac arrest, we want to make sure we understand what you want so it's on file for every time that you're in this hospital again. Another DNR discussion in the ER con that patients seem to voice is that we're going to kill them. Patients feel like if we know that they're a do not resuscitate, we're going to kill them because we know somebody that needs their organs. And that sounds crazy, but my grandmother is 79 and she believes this with her whole heart. She is not a DNR, which there's no reason she should be, but she's not a DNR because she feels like if she's a DNR and she's in a car wreck or she's at the hospital and she's dying, they're just going to let her die because somebody needs her organs. That's not true, and it is our responsibility as nurses to clarify this. Another actual con of the ER discussion pertaining to DNR orders is the time it takes to obtain these orders. To have a patient sign and understand DNR orders, the nurse teaches the patient that DNR orders mean that CPR will not be performed on them in the event of cardiac arrest. Then it's the nurse's responsibility to allocate for the patient so that a doctor comes to the patient and they also review DNR orders and what this means for the patient and that they confirm the patient understands. And then our social worker normally comes and has the patient sign the DNR order, and this process can take up to 30 minutes or so. And if the patient is just in the ER for some stitches, they often don't want to worry about this, and that's a big con of ER discussions pertaining to DNR orders, and is totally understood because nobody wants to be in the ER longer than they have to. Now, pros for an ER discussion about DNR orders is that we are, as nurses, allocating for patients to have autonomy about their death prior to dying. By having the ER discussion about do not resuscitate orders, patients are given the opportunity to really think about what they want to do. Even if they don't decide to be a DNR in that hospital visit, they at least have the information in their head that they've heard of this before, and if they decide that this is something they want, they can make up their mind at home, in the comfort of their home, while they're just talking about things with their family, or if it's a decision they want to make in private, they can do that also. By addressing this topic in the ER, we're also giving families and patients the opportunity to talk about something uncomfortable. Nobody really wants to talk about dying, and by simply asking a question and opening up the floor for the DNR discussion in the ER, we're saying it's okay to talk about this. You don't have to make any decisions today, but we want to know what you're feeling. And oftentimes families will say, yeah, Dad, or yes, Mom, what do you want us to do in the event that cardiopulmonary resuscitation needs to be performed on you? Now, the effects that having an ER discussion about do not resuscitate orders has on our nursing practice is endless. This discussion helps for nurses to have a clear understanding of their patient's wishes from the time they're admitted on. There's never a question about what the patient wants, and they can treat them as though they would every other patient, but in the event of their death, the patient gets to die in dignity. by dying how they want to die, without cardiopulmonary resuscitation or with cardiopulmonary resuscitation if the patient wants to be resuscitated. Also, a big thing that ER discussions pertaining to do not resuscitate orders have on our nursing practice is that nurses often have to witness something called a slow and show code. This is illegal. This is something that is not ethically correct, but a slow and show code is where medical professionals, the doctor, nurses, whomever, responds to a code very slowly, and they just kind of go through the motions, not doing exactly how they should, because they know that it's going to cause injury to the patient, and they know that this isn't what the patient wanted. This is not right, and it is our responsibility as nurses to not let that happen. But if a DNR order has been discussed in the ER and the patient has clarified what they want, it helps the whole team by knowing what a patient wishes in their final moments and if the patient wants to be resuscitated or not through CPR. The ER discussion pertaining to do not resuscitate orders is not an easy one, but it's something nurses, patients, and family members need to be aware of. It's our responsibility as nurses to allocate, advocate, and promote our patient's wishes at all times. And by knowing if the patient wants to be a DNR or not, we are able to let this patient die or live or have every opportunity at life or death that they wish. And that is our responsibility. Thank you so much for watching.